Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, the topic of my discussion is a common corneal infection, that is fungal keratitis. It was first time described in 1879 as a cause of corneal infection, fungal keratitis, and it may be caused by filamentous fungi, and it may also be caused by yeasts. Usually the cause of infection is a trauma, agriculture trauma, by vegetables or in the fields, something like that. And it also happens in immunocompromised patient or renal dialysis. Contact lens is also a source of such infections. So ocular surface disease, all these things can cause fungal infections in the cornea. Well, different types of studies has been conducted to find out what is the causative factor, which is the most common fungus in that specific area, that temperature, climate, and geography. So it has been found that in India, subcontinent region, excluding the southern area, aspergillus was the commonest cause of fungal infections. But when they conducted studies in the USA, fusarium was on the top of the list. While in UK, Candida was followed by aspergillus, and in China they found fusarium followed by aspergillus, and aspergillus followed by alternaria in the percentage of prevalence. There's a causative factor. When we talk about the trauma, what happens? That a trauma happens over there and the corneal epithelial integrity is lost, and as a barrier, which has a barrier effect also, protective barrier. So this fungus gets invaded into the stroma, it stays over there, multiplies, and starts spreading over there. Cornea, on the other hand, is an avascular structure, and that avascular structure has no blood supply, so has got weak defensive mechanisms. So these two things, fungus entering into the stroma and going deep down, and the weak defenses of avascular cornea, plus the release of toxins by the fungus, all contribute to the fungal infection, deep penetration, and causing more damage. Well, when we talk about the signs and symptoms, and symptoms, we talk the symptoms of the typical corneal congestion, decreased vision, redness, watering in the eyes. These are typical features. But when we go for the examination over there, we find out over there that usually the ulcer has a elevated form slough, hyphae lines, and feathery satellite stromal lesions. This is the characteristic feature. There are satellite lesions, you can find it over there. And once these patients come, very important is to go for the culture and sensitivity, that is gram staining, ginger staining, and then you can use sebarods, blood agar, thioglycolate, brain heart infusion, and even PCR can be done, which has relatively low specificity. When we talk about the treatment of different antifungal medicines, they are all fungistatic. No one is fungicidal. That's why they take a lot of time to be effective. Topically, commercially, only natamycin 5% is available for filamentous fungus. And then we can also prepare amphotericin B 0.15% to 0.3% and voriconazole 1%. We can prepare in our pharmacy, and it can be added with the oral voriconazole medication, these topical medications. Well, oral voriconazole, as I told you, different physicians have their different guidelines, so its role is a little bit controversial, but there is also TST therapy protocols that believes in topical, systemic, and targeted therapy. First line therapy, they believe, is 5% natamycin eye drops with adjunct oral voriconazole or ketoconazole medicines if corneal ulcer is more than 5 millimeter and depth is more than 50%. If good response comes, continue the same treatment. If the response is not good, they believe to add topical voriconazole. Still the fungal infection is not getting controlled, TST therapy believes that intracameral or intrastromal voriconazole can be considered for the treatment purpose. And if still after 4 weeks the treatment is not showing any response, penetrating keratoplasty as a therapeutic agent, therapeutic way to save the eyeball is another option. And even that, after they continue topical antifungals, systemic fluconazole or ketoconazole. In such a situation, the use of topical steroids is not that much advocated. Now I come towards my case of fungal keratitis. The patient, 46 years old, presented with decreased vision, counting finger, 4 feet, and the pressure was normal in both eyes. On examination, it is 4 into 4 millimeter area involved, stromal infiltrates over there, and staining was positive. Corneal edema was that much there, not that much thinning, and anterior chamber was +2 to +3 cells. So once we received this patient, we started admission and we did his culture and sensitivity, and after admission, topical vancomycin, ceftazidime, atropine eye drops, and considering the nature of the fungal infection, amphotericin and voriconazole eye drops fortified, these were started, and even the infection control department was also conducted to take permission and their guidance regarding oral antifungal medication. This is the slit lamp examination on the day 1. This patient, you can have a look over there how the infection has developed over there, and stromal infiltrates and satellite lesions, all these things are there, ciliary congestion, and mild corneal edema, anterior chamber +2 to +4 cells was there. So we started this treatment for the patient and awaited the culture sensitivity report. Once it came, it showed fungal infection, and the species was Fusarium. And in spite of our treatment, his pressure kept on increasing, eye pressure, it went up to 30. So we had to put him also on oral Diamox and topical Alphagon and Co-Soft eye drops. And the treatment continued for almost 10 days. But in spite of all the treatment, the condition was aggravating. The corneal ulcer, the stromal infiltrates, hypopion, everything was increasing. And even it was going to encroach the sclera. So at that point, after 10 days, we thought to better save the eyeball rather than later on we will think about the vision. So we discussed with the patient in detail all the pros and cons, and told him about the penetrating keratoplasty, another option to save the eyeball. And after this, we went for the therapeutic penetrating keratoplasty with intracameral antifungal medication. And after that, once it was done, the patient was continued on the topical antifungal medication, topical moxifloxacin eye drops, and oral antifungal medication, voriconazole, keeping an eye on the LFTs and RFTs. And you can see the next slide how the things changed, and we opted for the penetrating keratoplasty. This slide you can see how the condition deteriorated, hypopion has developed, fungal infection is increasing in spite of the maximum treatment, and ciliary congestion was there. Of course, that much infection is there, ciliary congestion. It is understandable to pressure to rise that high even after 30 millimeter of mercury. So this was the situation. So this is the condition. You can see that therapeutic penetrating keratoplasty was done. All that corneal area was removed and sent for the microbiology. And even after that, the patient was continued on topical antifungal medication, oral antifungal, and we also used cyclosporine eye drops to inhibit and decrease the chances of graft rejection. So this is the condition you can see after this one. So our target at that stage was that to protect and save the eyeball rather than to later on think about the vision. Right throughout this treatment which we carried out repeatedly, we did the ultrasounds to see that any extension of infection into vitreous or endophthalmitis. This is an ultrasound report, and the vitreous was never involved. There was no endophthalmitis, and we were alhamdulillah successful in saving the eyeball. So the thing I wanted to say during this presentation was that the fungal infection is a very challenging disease to handle. It takes months to control the infection, and even sometimes, in spite of your full efforts, you cannot control the infection. At that stage, a timely decision has to be taken for the therapeutic penetrating keratoplasty. And I want to thank Prof. Hani Mazeni, Senior Professor, Corneal Refractive Surgery, King Saud University, for giving me these pictures. And the literature review was done from the Stat Pearls, that is Fungal Keratitis by Gabriel Castano and Ayman G. Al-Nahri. So I also want to thank my respected audience for attending this presentation. Thank you.